Hello everyone, welcome to my channel Physiopath Education. Myself Dr. Orchid Biswas. Today we are going to study or decode the MPT entrance examination questions. It will be helpful for the MPT examinations as well as the common entrance examination of all the universities, as well as these are the questions or MCQs which are helpful for the preparatory for CRE or common recruitment examination of AIMS, RRB, railway, and even state government employment for physiotherapist. So let's start. So number one question is from the Parkinsonism. Question is Parkinsonism. Parkinsonism disease has combination of tremor, bradykinesia and muscle rigidity. Number B, chorea and muscles hypotonia. Number C, tremor, ataxia and muscle hypotonia, or periacrosis and muscle spasticity. So what will be the correct answer? You will know the Parkinsonism disease. What is the Parkinsonism disease? Disease or PD is due to degeneration of dopaminergic neurons in the SG cell or substantia nigra cell. So Parkinsonism is due to degeneration of dopaminergic neurons in the SG cells. What is SG cells? That is substantia nigra cells. So in the clinical features of Parkinsonism, there is a classical triad of Parkinsonism. Classical triad of Parkinsonism. So what the classical triad? Number one is resting tremor. What is the resting tremor? That will be the pedal rolling tremor. Another is bradykinesia, that is the slowness of movement. What is the bradykinesia? That is the slowness of movement. And another feature is rigidity, that is either lead pipe rigidity or cogwheel rigidity. So these are the classical triad for Parkinsonism disease. So here from the answers you can see the tremor, Parkinsonism is the combination of tremor, bradykinesia and muscles rigidity. That is the answer will be the number A. So why not chorea and muscles? Chorea and muscles hypotonia, and chorea and muscle hypotonia is seen in the Huntington disease. Huntington disease. This combination chorea with the muscle hypotonia and the tremor, ataxia and muscle hypertonia, this combination is seen in ataxia or ataxia. Sorry about that. Tremor, ataxia and muscle hypertonia is any type of cerebellar disorder. But Parkinsonism is not a cerebellar disorder. It is a disorder of degeneration of the dopaminergic neurons in the substantia nigra cell. So, and this combination perichrosis and muscle spasticity normally seen in any type of UMN lesion. Any type of UMN lesion. So the answer will be the tremor, bradykinesia or rigidity. Answer number 1, A. So we'll go to the next question. In details we can learn about the Parkinsonism disease, the pathology you can say. I can also say about the details Parkinsonism disease now. Okay, we'll go to the details Parkinsonism disease in today's class.
In historical pathology, King's evil, scrofula, was a form of tuberculosis affecting lymph nodes.
Okay, we will go details discussions of this in our next class, where we will read about the details of the Parkinsonism disease. Will very shortly I will upload a video about that. So we'll go to the next question. Next question is the most commonly used scale for classification of sensory motor assessment of spinal cord injury or SCI. The most commonly used scale for spinal cord injury is number A, Oddifidas-Worth scale, number B, Barthel index, number C, ASIA scale, and number D, functional independence measure. Here the correct answer will be ASIA scale. What is ASIA scale? The full form of ASIA scale is the American Spinal Injury Association impairment scale. It is the gold standard scale. Okay, so what the ACS scales assess here, from the question you can see the ACS scale assess the sensory motor assessment, the detailed sensory motor assessment, along with the, so what the ACS scale assess. It assess motor level of injury, sensory level of injury, neurological level of injury, and completeness of injury. That is A to E grading. Here in details, in motor level of injury, there are, it assesses from the 10 key muscles. In the sensory level of injury, it assesses 28 dermatomes level. Completeness is the A to E grading. So now we'll go to the grading. A, complete injury. B, sensory incomplete injury. C, motor incomplete injury, where muscle power is less than 3 out of 5 power. D is motor incomplete, where the muscle power is greater than 3 out of 5 power. E is normal. So these are the ACS scale for assessment of, what is ACS scale? Assessment of the spinal cord injury. Spinal cord injury. It is the gold standard for any neurological classification of SCI, the ACS scale. Okay, so the answer will be the ACS scale. So what will be the others option? The other option is, this is wrongly pronounced. This will be Arthwa scale. Okay, it is incomplete. It will be modified Arthwa scale. Okay, the answer modified Artsva scale. The modified Artsva scale is for spasticity grading. The Barthel index is for activity of daily living or ADL assessment. And the functional independence measure, it is for the disability measurement. Disability measurement. Okay. So we'll go to the next question. Number 3 question is the decorticate rigidity. In decorticate rigidity, the following distribution of hypertonia is seen. So you have to divide it into two parts. One is the decorticate rigidity. So first and next, distribution of hypertonia. So we'll go to number 1 part, that is the decorticate rigidity. So what is the decorticate rigidity? That is the any lesion or injury above the red nucleus. That is red nucleus, so that is the cortex or internal capsule. So cortex or internal capsule. So what will be the mechanism of this decortication? That will be the mechanism. Number 1 is the rubrospinal tract intact. Due to the intactness of the rubrospinal tract, there will be, this will occurs flexion or flexes the upper limb. And next with the vestibulospinal tract unopposed. Vestibulospinal tract unopposed, that will leads to extension of lower limb. So the mechanism is the rubrospinal tract intact, that goes to the flexion of the upper limb, and vestibulospinal tract is unopposed. Due to that unopposed, the extension of the lower limb occurs. Okay. Now what will be the posture in this? The posture will be arm flexed legs extends, arm flexion due to the rubrospinal tract intactness, and leg extension due to vestibulospinal tract unopposed, and it indicates severe cortical damage. Severe cortical damage. So what is the another word? Decorticate of the, or opposite word of the decortication. Here is the decorticate rigidity. Another one is the what is the opposite, or here what? One is decorticate, injury above the red nucleus. Another one is decerebrate. One is decorticate, another one is decerebrate. Now we'll differentiate the decortication and decerebration. In decortication, upper limb flexed. Here decerebrate, upper limb extended. Here the lesion or injury above the red nucleus, that is the cortex or internal capsule. Here the lesion is below the red nucleus. It has better prognosis, worse prognosis. So now we'll go to the question. In decorticate rigidity, distribution of hypertonia. The hypertonia distribution, where will be the distribution of hypertonia? You will see it will be answer will be number B, flexion in the upper limb and extension in the lower limb. In short term, decorticate you can memorize this from decorticate is equal to core. D is equal to you can say core. Core means arms towards the core. Okay. So here will be the common answer. And decerebrate, there will be extension in the upper limb. Okay, extension in the upper limb. It will be the answer for the decerebrate. And next We'll go to number 4. Number 4 question is, one of the following symptoms is not features in Bell's palsy. Bell's palsy. So, first of all, we have to know about the Bell's palsy. What is Bell's palsy? It is a LMN or lower motor neuron type of facial paralysis. Involving seventh cranial nerve or cranial nerve seventh. Okay, cranial nerve seventh is involved, where there will be it is the element type of facial paralysis where the seventh cranial nerve is involved. What are the features or clinical features? You can see the questions here. You can see one of the following symptom is not feature. So if you know about the clinical features, you can easily strike the correct answer. So what are the clinical features here? Number 1, it is acute in onset. Next one is unilateral facial paralysis. Next is inability to close eye. Next is hyperacusis. What is hyperacusis? Where there is involvement of the stapedius muscle or muscle paralysis. Stapedius muscle paralysis. And next is decreased lacrimation. If the lesion is proximal. So these are the clinical features. Acute in onset, unilateral facial paralysis, inability to closure of the eye or close the eye, hyperacusis, that is the stapedius muscle paralysis, and decrease lacrimation. So we'll now go to the why there is decreased lacrimation due to greater petrosal nerve supplies the lacrimal gland. So if the lesion is proximal, then the tear secretion will decreased. So from here we can easily go through the correct answer from these. Acute onset, one of the clinical features. Here we have to find out one of the following symptoms is not feature. So acute onset, this is correct. Intact unilateral involvement of the face, this one is also correct. Hyperacusis, this one is also correct. And here is the intact lacrimacil, this one is incorrect. So if in Bell's palsy there is decreased lacrimation, in Bell's palsy there is decreased lacrimation. Okay. So the next question is the recurring involuntary movement which has a rhythm. That means the rhythmical recurring involuntary movement. What is rhythmical recurring involuntary movement? So number A option is chorea, B athetosis, number C tremor, and number D, that is dystonia. So what these all are the movement disorder. This all chorea, athetosis, tremor and dystonia. So what will be the answer? Before going to the answer, we'll know about the nature of movement occurs in these movement disorders. Nature of movements. So first is we will know about the nature of movement in this movement disorder. At first there is the chorea. In chorea there is irregular jerky movement. Athetosis that is the slow writing movement. In dystonia, sustained contraction. And tremor, that is rhythmical movement. So from here you can see the answer. The chorea, that is the irregular jerky movement. From the question is rhythmical involuntary movement. Rhythmical. Okay. Rhythmical involuntary movement. Rhythmical involuntary movement occurs in the tremor. See, in tremor, that is rhythmical movement. Chorea is the irregular jerky movement. athetosis slow writing movement, and dystonia is the sustained contraction of the muscle. These all are the movement disorders. Now we'll shift to the next question, number 6. The truncal ataxia is a feature of. Okay. So first we'll read what is truncal ataxia. Okay. Truncal ataxia is the form of ataxia characterized by inability to maintain upright posture and balance of the trunk, most importantly. That's why it is known as the truncal ataxia. Especially while sitting or standing due to midline cerebellar or Varmis. The midline cerebellar is known as the Varmis involvement. So the midline cerebellar involvement. Truncal ataxia is a form of ataxia characterized by inability to maintain upright posture and balance of the trunk, especially trunk only. So that's why known as the truncal ataxia, especially while sitting or standing due to midline cerebellar or Varmis involvement. So what was the question? The question was the truncal ataxia is a feature of midbrain involvement. Number B, pontine lesion. Number C, brainstem lesion. And number D, midline cerebellar lesion. So answer will be number D, midline cerebellar lesion. Normally in ataxia where there is the involvement of Varmis, so or midline cerebellar, involvement of Varmis affect the trunk or truncal ataxia. When there is hemisphere involvement, there will be limbs and fluconodular part involvement, fluconodular part involvement, there will be disturbance in the balance or vestibular disturbance. So when there is the lesion, any lesion in the vermis, the truncal ataxia occurs. In truncal ataxia, you will see wide based get truncal instability and difficulty in sitting unsupported. Okay. So the truncal features of the truncal ataxia of midline cerebellar lesion. Next, we'll go to question number 7. The inability to register and integrate stimuli from the side of paralysis. You have to read the question very thoroughly before answering the question. The inability to register and integrate stimuli from the side of paralysis is known as. So, number A, somatoagnosia. Number B, right to left discrimination disorder. Number C, unilateral neglect. And number D, anosognosia. So before going to the answers, first we'll have to know about this. So what is somatoagnosia? First, somatoagnosia is the loss of body awareness. Next is right, left disorientation. That right left inability to identify which one is his right side and which one is his left side. That is right left disorientation. So normally it occurs in Jarts-Mann syndrome. Next is anosognosia. That is the denial of any illness. When patient is in denial of he or her having any illness, that is known as the anosognosia. And the unilateral neglect is inattention to one side of the body. So what will be the answer? The question is the inability to register or integrate the stimuli from the side of paralysis is known as. The answer will be unilateral neglect. Okay, normally this unilateral neglect occurs, the lesions, when there is the lesion, the unilateral neglect occurs when there is lesion in the right parietal lobe. So unilateral neglect is the inattention or failure to attend one side of the body. Failure to attend one side of the body. And here the clinical signs are the ignores in this lesion of the right parietal lobe. Here the clinical signs ignores left side of the body normally. The patient eats food only from one side. He or she will draw half clock. Here, this half clock. Okay. So the next question is, amyotrophic lateral sclerosis shows clinical features of amyotrophic lateral sclerosis, also known as ALS in short. ALS shows the clinical features of number A, cerebellar sign, number B, upper motor neuron lesion, number C, lower motor neuron lesion, and number D, upper motor and lower motor neuron lesion. So we'll go what is, firstly we'll know about the amyotrophic lateral sclerosis. What is amyotrophic lateral sclerosis and its clinical features? Okay. ALS, amyotrophic lateral sclerosis, is a progressive neurodegenerative disorder involving corticospinal tract, as well as the anterior horn cell of the spinal cord, anterior horn cell of the spinal cord, as well as motor nuclei of brainstem. So ALS is a progressive neurodegenerative disorder involving the corticospinal tract as well as the anterior horn cell with the motor nuclei of the brainstem. So when there is involvement in the corticospinal tract, that means there will be symptoms of upper motor neuron lesion or UMN symptom. Okay, you know about the upper motor neuron trained to the anterior horn cell of the spinal cord is known as the UMN, and here there is also involvement of the anterior horn cell and the motor nuclei of the brainstem. So here also there is LMN type of symptom. occurs. So then that's why, because these both pathway, this brain to anterior horn cell of the spinal cord and anterior horn cell of the spinal cord to the motor unit, this both pathway, this is UMN pathway, this is LMN pathway. Because of this both pathway, degenerate, patients show mixed UMN plus LMN picture or features. Now you can say why there is UMN plus LMN features. The UMN features damage, or UMN features causes the spasticity, the hyperreflexia, the clonus, Babinski sign positive, and increased muscle tone, or that is known as hypertonia. And there is element type of damage. There will be atrophy or muscle wasting. As well as there will be fasciculation, along with hypotonia. Here is hypertonia, hypotonia, and there will be muscle weakness. So the answer of this question will be amyotrophic lateral sclerosis shows clinical features of cerebellar signs, not cerebral. The cerebellar signs are the ataxia, intense and tremor, not in ALS. Next, it upper motor neuron lesion, not only the upper motor neuron, not normally seen in the primary lateral sclerosis. It is seen as the primary lateral sclerosis, and lower motor neuron seen in the lesion seen in the progressive muscular atrophy. Muscular atrophy. So answer will be number D. ALS is the upper motor plus and lower motor both. Upper motor and lower motor neuron lesion. Okay. Now we'll go to the next question, number 9, that is loss of abnormality of psychological, physiological or anatomical structure or function in a human being is known as, number A option impairment, number B limitation of activity, number C disability, and number D participation or restriction. Participation, restriction. Okay. Now before going to the answer, we have to know about the WHO or World Health Organization ICF framework. ICF is International Classification of Functioning. That is International Classification of Functioning. Okay, so the WHO ICF framework divides the health condition impact the health condition impact into one, body function and structure, number 2, activity, number 3, participation, number 4 is contextual factors. Okay, so these are the health condition impact. So here we'll go to the question, that is the loss of abnormality of psychological, physiological or anatomical structure or function in a human being is known as. Okay, so we'll go what are the impairment, what is the limitation of activity, disability or participation restriction. Okay, at first there go to the impairment. What is impairment? That is the problem in body structure or function. Just like as per example, muscle weakness, decreased range of motion, these are the impairment. Memory loss. Okay. Next it is the activity limitation. There is activity limitation or difficulty, you can say it is the difficulty in next question number 10. Which of the following below is not a contextual factor domain? Here contextual factor domain according to the International Classification of Functionary Disabilities and Health. Okay, question number 10. Which of the following below is not a contextual? Here important part, the contextual. सबको ये कॉन्टेक्सचुअल फैक्टर जो है उसको दिमाग में रखना है. कॉन्टेक्सचुअल फैक्टर, व्हाट आर द कॉन्टेक्सचुअल फैक्टर, यू हैव टू नो about the firstly, what is the contextual factor? Contextual factors, or what you can say, what are the contextual factors? What are the contextual factor? They are not body functions, any body functions. What are they? They include the number A, environmental factors, thus include the environmental factors are the workplace, school, social support, accessibility, etc. And number B is the personal factors. So the personal factors means the age of the education and motivation. Here the answer, which of the following below is not a contextual factor? Okay, the question is not a contextual factor domain according to the International Classification of Functionary Disability and Health. So workplace and school involvement, there is workplace involvement, school involvement in the contextual factor, so this will not be the answer. Next is the community activities, any type of community social activity or community activity. Okay, this will not be the answer. Recreational activities is also will be not the answer, will be the affected perceptual function. What is the, why the answer will be the affected perceptual function? The affected perceptual function belongs to body function domain. So these are not the body function. Conceptual factor are not the body function domain. Our perceptual function belongs to the body function domain. So the answer will be number C, the affected perceptual function.